It's a pleasure to have with us today, Jay Battacharya from Stanford University, Professor of Medicine and Professor of Economics. Jay, thanks for joining us at the Salem Center for Policy.
It's my pleasure, Carlos.
So Jay, in all these interviews that I'm conducting, I'm asking people to try to go back in time and think about the evidence and the sort of information they had in place and start thinking about the COVID back in March. So what was the first sort of a set of information and evidence that really, start getting your attention to the problem?
So, okay, so I go back to March. I've been doing work on economic epidemiology for a long time, and I did some work on the H1n1 flu epidemic in 2009. And in March, I thought back to what we knew about the mortality rate in H1n1 and how that evolved over time. So very early on, there were case reports in the H1n1, this is 2009, epidemic about enormously high mortality rates, case fatality rates, what we call them now, right? So from H1n1. And in fact, like Argentina, there was reports of 14%, typically worldwide, it was like 1, 2, 3%. Very, very high. 3% is a really high. 3 in 100 people die from a disease. It's enormously high. And what happened in H1n1 was that seroprevalence studies started to come out that found that there were about 100 times more cases, infections, than there were cases. 100 times more. Seroprevalence studies, as your audience probably knows, are studies of antibodies in the blood of people. And seroprevalence studies attempt to measure, attempt to be a population number, rather than just looking at people who come down with the illness and are identified by doctors and then tested to see if you have the virus. Seroprevalence looks for antibody evidence, says, okay, yeah, even though you may not have shown up to the doctor with the disease, you had it because the antibodies that are specific to the disease say that you had it. And in the case of H1n1, it turned out to be 100 times more cases, infections than cases. And the mortality.
Sorry to interrupt that. So when you say 100 times, that's probably a lower bound, right? Because our ability to detect antibodies is also restricted, right? It takes a while to detect, because they go away, right, after a few months.
Yeah, that's right. In fact, that turns out to be, I think, even more important in the case of COVID than in the H1n1 case. And not everybody reacts to antibodies with antibodies as strongly as other people. So it really is. It is a lower bound. It's probably lower. It's probably more than 100. In any case, with that 100-fold, the infection fatality rate turned out to be about somewhere between 0.01 and 0.02%.
Okay. 1
in 10,000 to 2 in 10,000, whereas the initial estimates were on the order of 1 in 100 to much higher. Okay, so I remembered that. I mean, that was my very first thought when I saw the case fatality rate estimates that were out in the public in COVID. And so, I mean, I suppose it's not that unusual to wonder, and that's what I did. I just wondered, maybe, do we have that situation now? And I looked around and no one seemed to be talking about that, which was really odd to me. It seemed like one of the most obvious lessons. I remembered it from the H1n1 epidemic. Why should we not consider that as a possibility now? Everyone's attention was focused on the people who were dying in the hospitals with the severe viral pneumonia, which was absolutely terrible. But we didn't know. I mean, I didn't know how widespread it was. I mean, you shouldn't extrapolate from a previous disease. It could be 100 to 1. It could be 10 to 1. Who knows what it is? So I worked with some of my friends, and colleagues here and elsewhere, to start up some of these seroprevalence studies to try to get that number. And I think a lot of the discussion that led to the lockdown was it struck me as in the absence of that vital piece of information. How widespread is it and how deadly is it? Unless you have that, you can't get any reasonable discussion about the cost and benefits of a lockdown. And just so we're clear, the lockdown itself was an extraordinary decision. I don't think that I can think. I mean, you have to go back to 1918 to find some evidence, something similar policy of such widespread cessation of all activity as a way to combat a disease spread. It's unique in my experience.
Even then, I think it wasn't as extreme, right? In the spread of the lockdown, it was like specific to some cities and so on, right?
Yeah, it was a universal lockdown. And it just followed one after the other, one country after the other, basically decided on the basis of, I think, almost no evidence that this was the only way to address the epidemic. I think when you do an extraordinary policy like a lockdown, you need extraordinary evidence. And we did it with the absence of that kind of evidence.
So so go back a little bit, right? So when we're looking at the evidence, then you had experience with H1N1, and presumably the epidemiologists at a time involved with H1N1, which I'm sure the types of what they call it, SIR models that are put in place to study viruses, they're not that different, the ones that were used for H1N1, right? And one of the things yeah, it's all exactly right. So one of the inputs for those models is the infection fatality rate. They have to make assumptions about, okay, if this thing infects this many people, how many people are going to die, and then make those projections. So from your description of what the difference between the initial case fatality rate on H1N1 and the actual IFRs, infection fatality rates that were found later on, that probably was a huge discrepancy in the epidemiological predictions at first, and quickly in a span of I don't know, what was the span of time between the initial case?
It took months in the case of H1N1 to get to the right number. That's why that was what motivated trying to go fast. I wanted the conversation to move very quickly to actual numbers using these seroprevalence studies as opposed. That was my whole goal, actually, was to get the people who were populating these models to populate them with parameters that had some evidence behind them, as opposed to make things they were just guessing.
Right, right. So that time during H1N1. So what I'm trying to say is that what would you sort of pinpoint as the difference between why didn't we freak out and lock the world down under H1N1, given that there was some indication of this is a flu that goes around pretty quickly, is pretty aggressive in terms of it's contagious, it might be killing 3% of people. What was different then?
I think the single biggest difference in the early discussion of H1N1 was the possibility of very quickly getting a vaccine. I mean, they rushed the vaccine, and people were worried, okay, is this vaccine safe? But we have a lot of experience with flu vaccine. We have a lot of experience with developing them, with sort of assuring that they're safe, and we have a mechanism to deploy them in a wide-scale setting. None of that was true in the case of COVID. I think that the ability to develop that vaccine so quickly in the case of H1N1 really did calm down the public policy response. And then the seroprevalence studies started coming out, and we're like, okay, we got very lucky, right? The thing was not as deadly as we thought it was, thank God, right? And we have a vaccine quickly, it's all over. But in some sense, it was happenstance, right? We know now it was happenstance because the thing turned out to not be so deadly, and it happened to be the flu, so we have a vaccine platform. H1N1 so different from COVID in that sense. No vaccine platform. We have this deadly number, this 3% number. In fact, I think the Imperial College model, they populate, their initial IFR was like 1% in their model. That's what led to the 2 million death prediction. 2.2
million deaths, right.
And they use these these Bayesian kind of, like it's like these models that they're under-identified. Like there's all these parameters, and they're fitting it to not very many hard endpoints, and they're like fine, they have some Bayesian fit to like try to get the parameters to work, but who the hell knows if those are right? You really need to populate some of those numbers with actual data on drawn from studies like seroprevalence studies to have any confidence in them.
Right. Well, and on top of it, I think those models they lack the human element to it. Like once you understand things, once we start reacting to it, the exponential growth that they assume and those things were just assumed, and they're like,
that's
and of course that's not how the world works, right?
Yeah, I mean that's a classic problem that economic epidemiology addresses, right? So the idea is that people respond. So the elasticity of demand for self-protection is a function of the prevalence of the disease, the perceived dangerousness of the disease. So when the danger is going up, people will automatically voluntarily engage in self-protection, hand washing, other kind of mitigation activities. They won't go out to baseball games or whatever. Right. So I mean that is not in any of those models. There are all these very, very detailed compartment models, but that kind of feedback of how prevalence changes behavior is not in any of the models. And of course, as you pointed out, the models tend to be these homogeneous models of mixing, and we know for certain that there's no homogeneous mixing. That in fact, there's like people mix with very heterogeneous ways. And in fact, even you can go further. People who believe that they're highest risk respond more dramatically with reductions in social mixing, and the models don't have any of that in there.
Right, right. So
But that's a perennial problem. But that IFR number drove everything. It scales up and down with that IFR number in those models. So if the IFR number really was 100 times, it turns out not to be 100 times less. Just we can jump forward. I think it turns out to be about 5 to 10 times less than that. Probably 5 times less than that. In any case, the number of deaths scales with the IFR in those models.
So let's go back to then when we used you try to push forward to do something fast, right? To get a seroprevalence study done as quick as possible. Then tell us about the Santa Clara study.
Sure. So yeah, that was the first of 3 seroprevalence studies I've been involved with. The Santa Clara study, we organized it at a speed, and all the credit goes to Dr. Iran Ben-David. Actually, one of my very first students ever. Said he's down the hall from me, and he organized it in a incredibly rapid way. And it was actually a really nice feeling. There were all kinds of folks around the Stanford community that came together, volunteer their time. Medical students offering their time. My family were volunteers. Iran's family were volunteers in helping set up things and enter data, all this kind of stuff. Yeah, I mean, it was, and normally a study like that, where we drew blood from, 2,000 more, a whole bunch of, a very, very large number of people in the community, would have taken a year or more to set up and get permissions. We managed to do it in a matter of weeks. Partly this happened because we were using a test platform called a lateral flow assay test. It's a little tiny, it looks for all the world like a little pregnancy kit, but it measures antibodies that are specific to SARS-CoV-2. Now the FDA had provided a authorization to commercialize those kits in the US in March for research purposes. Mm-hmm. They weren't authorized for clinical use in the population, but for our use, it was perfect. And we knew a fair bit about the test kit we used. It looked like it had pretty good sensitivity and specificity properties. I mean, we turned out we were going to learn a lot more about the kits, but in March they look promising, let's just say, in terms of sensitivity and specificity properties. We powered up our study, said, okay, we don't know the prevalence, but let's say, and we made a bet, the main authors of the study, about what we thought the prevalence was going to be. I thought it was going to be much higher than it turned out to be. That's why you do the number. That's why you run the study, right? My co-authors thought it would be lower, and we powered it with their guess because we wanted to be conservative. And lower means you need a large sample size, so we powered with a very pretty large sample size. And we collected over 2 days. We collected thousands of samples. The test kit, the nice property about the test kit for fielding it in the context of a lockdown was we could just draw blood off a finger stick. The people just came up, drove up, they stuck their finger out the window, didn't expose the person pulling the blood or to anyone to any sort of respiratory droplets. We don't know what the risk is, so we have everybody mask up and wear gloves and all that kind of stuff, and having that essentially the car window shield was another level of protection. If we had tried to get there are another set of tests called ELISAs. ELISAs you have to run in a lab, and you need a venous blood draw. At least you did back then, a venous blood draw and it's getting a venous blood draw is it's a big deal. You got to pull. It's hard to do in a setting like that. It would have been impossible. Right. Couldn't have run the study like that.
So presumably the second type of test would be more precise, right?
Yeah, I mean, although in retrospect, it turned out it's not as bad as, the little kit we used turned out to be fantastically precise, which I'll tell you about in a minute. So we ran the study and found a prevalence of 2.8%, which turns out to be about 50 positives out of I forget the number, what the denominator is. But in any case, now there were a couple of aspects on the sampling. We're talking about econometrics and stuff, right? So we can talk about that. The sampling of the study, we did this very, very rapid sampling through Facebook to sign people up, and it turns out that is not a representative sample, not surprisingly. So we reweighted the population to make it look like the demographics of the county. And so if you just do the unweighted, it's like 1.5%. With it turns out like 2-to-1 women signed up relative to men. It undersampled some of the zip codes where there were poor populations, in fact, by a fair bit. So we reweighted so that it matched the zip, sex, and race sort of mix of Santa Clara County. And that's where you get the 2.8%. So with that 2.8%, that turns out to be about 50,000 cases if you extrapolate the county at large. Mm-hmm. And of course, that excludes jails and other institutionalized populations that weren't sampled. Up to date, in the county, there have been up 1,000 identified cases. 1,000 identified cases. So that means we had a multiplier by 50-to-1. If you allow for a death lag, it turns out that the infection fatality rate was somewhere on the order of 2 in 1,000 after you did all that. Whereas the case fatality rate at the time was about 10% in Santa Clara County.
Oh wow!
So 50-to-1 difference in the case fatality rate versus the infection fatality rate. Okay,
so we're talking here, just summarize, right? So you're talking about a 10% case fatality rate in the county, and you're looking at an IFR estimate of about 0.25 or something like that.
0.2. Actually, it was at 0.2 for Santa Clara.
Okay. 0.2.
Yeah, in LA County, we ran a very, very similar study, and it was again, the multiplier was like 40 rather than 50, but almost the same IFR. Almost the same IFR. A little bit higher, I think, in LA than in Santa Clara County, but nothing to write home about. Okay, so I also worked on the Major League Baseball study, which we can talk about if you want, but these two are sort of the central studies that have drawn focus. Okay, so we send out the LA County study, which we conducted a week after the Santa Clara study, to JAMA for review. Mm-hmm. It gets accepted almost immediately. It's published. Almost no notice.
And that's the JAMA, the premier medical journal in the world.
Journal of the American Medical Association. We decided we wanted to get out the message quickly on the Santa Clara study. So we put it on a preprint server, kind of like economists are used to NBER. That's normal for economists because it takes so long to get any paper.
To get a paper published, right?
And so we're used to essentially what are called in medicine preprint servers. We put up those working papers. We discuss them ad nauseum long before they see print. By the time they see print, it's really old news, right? In medicine, that's a new thing. In medicine, what the norm is, you don't say anything about the paper until it's published.
Right.
In recent years, this open science model has started to take over medicine. These open model, and actually, I think it's been really healthy for medicine because having these preprints, it allows there to be a much broader set of people discussing these things. I mean, it's mixed. I mean, sometimes the discussion is not that productive, but that's true in economics too, I think. Right. So we released it through this preprint, and Twitter and the whole world exploded. I've never had 10,000 referee reports in my life up to that time, way less than that. But I literally, within a day, I had 10,000 referee reports in my inbox all at once. So
a lot of hate posts out there. I remember reading some things from colleagues that I think are, very thoughtful in general. I was like, whoa. I'm not going to name names here, but there's a prominent statistics blog that was very mean to your team.
Yeah, I mean, like the statisticians, and some of it was justified. So we made a mistake in the calculation with the standard errors, and which we corrected.
Because of the weighting, right?
Yeah, no, actually, so it was literally just like that. So the formula we have to, so the statistics involve this. So you have to correct for how sensitive and specific the test is, mm-hmm. The false positive rate and the false negative rate. So we did that. We had a formula that corrects for the sensitivity and specificity, and it was my fault. The sample sizes for the sensitivity and specificity are not the same as the sample sizes for the study at large, and I didn't take that into account.
Okay.
In the initial thing. But a week later, we issued, this is how preprints work. You can update them.
That's science,
not
right?
Published.
That's right.
Yeah, I mean, it was, and in fact, my view of that was, this was a really productive thing. I got the 10,000 referee reports. We took the important parts of it, we revised it, and we updated it.
Right.
And if we learn, The other thing that happened,
and to be clear, that didn't change your estimate, right? That changed your uncertainty about it, maybe a little bit wider uncertainty on that range, right?
Yes, exactly. And I'll say this, the other thing that happened was that because of the open science model, a very large number of people turned out had worked to evaluate the sensitivity and specificity of that specific test we were using. It's called this Premier Biotech Kit. So we got, we went from about 400 samples for the specificity number to about over 1,000. Over 3,000. Over 1,000. I can't remember, misremembering the number, but like a very large number of samples all of a sudden about both the sensitivity and specificity, just greatly decreasing the actual standard error. Right. So after we corrected, it was the standard errors were a little bit wider. The point estimate was the same. Maybe not that surprising, right? Right. And it turns out that the kit is incredibly sensitive and incredibly specific. Like, so 99.6 or 99.5 specific on that order. So 5 false positives out of 1,000.
Okay.
It's that turns out to be the main number, because it's like in a low prevalence environment, false positives can kill you. So it was a very low false positive rate at the point estimate, and after we got all those independent tests of the test kit, we learned that the standard error for that was much smaller than we realized when we released version 1. There were a lot of like false things on, there was a very prominent post on Medium arguing that all of our positives could be false positives, which turns out not to be true.
True, right.
It just, and the other thing is anyways, I think that science was fine. I was actually happy with that. I think that's how open science is supposed to work. And I learned stuff, and I think we know more. We have more confidence in the study as a result of that discussion. It's good. It's good science. What I didn't expect was the media. BuzzFeed attacked my family, which was really annoying. Like, so my wife, I told you, participated in the study. She's a doctor. She's an oncologist. She wrote to her friends because she was all excited about the study to get to participate, and somebody leaked the email she wrote, which had there was some information that wasn't correct in it, to BuzzFeed, who decided to make her into a national story. The funding for the study was small donors, all to Stanford. I took no personal money for the study. And one of the donors who gave money after the study was a JetBlue executive, David Nealman, who's interested in the results of the study. He's interested in the results of the study. Okay, he gave $5,000 to Stanford, and BuzzFeed wrote an article accusing me of conflict of interest, outrageously. It was really, really annoying to have to deal with all of this. And in the midst of it, Stanford itself actually acted in ways, I think, that attacked my academic freedom, which we can go into in a bit. I've been very, very disappointed with Stanford leadership on this front, because I'd always thought of Stanford as a place that respected academic. I've been here since my undergrad was here. I did my graduate school here. I did my MD here. I've always loved that we have a motto is that in German, let the winds of freedom blow. I don't believe that anymore.
No longer the case, right? Yeah.
Yeah, I don't believe that's true about Stanford anymore, at least not in their current leadership.
And I wouldn't point out to Stanford specifically on that problem, right? I think that had you been in a lot of different places, my guess.
I know, but this is
right now. University has been pretty.
It's home for me. It came as a shock, right? It's like you. Anyway, so enough about me. That was really a stressful time as a result of it. I wish it was just about the science. The other thing I didn't fully expect was the political angle of it. Like, why is the IFR of this disease a political fight?
You became a rabid Republican as a result of that paper, right?
Well, it's just, I'll tell you, like my colleagues, my senior colleague, Johnny Unides, who worked on the study with me, I have no idea what his politics are. I really don't. I never talk. Why would I talk to Johnny Unides about politics when I could learn from him 500 other things that are way more interesting and important, right? And Iran, I'm pretty sure there's a lot of politics we don't share, but I don't care because he's a brilliant scientist, and I learn from him every time I talk with him about something important. So I just, it was really, really weird. Like, it doesn't matter. Like, I've always thought that. Like, I write with everybody. I mean, you can look at my CV. I've written with people of all different political stripes. It doesn't, I frankly, most of the time, I don't know what the political stripes are because it doesn't make any difference.
And to be clear, right, one of the things that your study was providing was the potential evidence for us to be able to make a more informed decision about what to do and what not to do. And it was not at all pointing out, oh, here's what you should do or should not do, right? That's, I guess, in the realm of politics.
Yeah, I mean, like the IFR. Okay, so, I mean, obviously the policy is going to be different if you think that the death rate's 3 in 100 than if it's 2 in 1,000.
Right.
Right. You have to have a different policy. Otherwise, why you're not doing it right.
Right.
But shouldn't it be informed by that? So anyways, we put this study out and it creates this like huge firestorm of attack on us. And you know, the economists are writing me saying, oh, no, it can't be that low. Look at New York.
Right.
And the problem is, like, it gets the medicine wrong. The IFR is not just a single number that's a feature of the virus. It's a function of the host and the virus and the health policy setting in which the cases are managed. So if you're in a setting where you can't get good medical care, you're gonna have a very high IFR.
Right.
If you're in a setting where the bug hits old people in nursing homes, you're gonna have a very high IFR. Right? If it's hitting basically young, healthy people, that actually, it turns out that the death rate from this is really age stratified. So like, if you're over 65, this is much worse than the flu, much worse than the flu. If you're under 40, it's better. You'd rather have this than the flu, and it's not close. I mean, for instance, among kids in the U.S., I think somewhere on the order of 3 times more kids have died of the flu this year than of COVID-19.
Which by any measure has been a very mild flu season, right? Which is hard for us to separate because a lot of it's, you know, COVID and flu versus flu and
yeah, although there's just like emerging evidence, so you can't get both at the same time. I don't know. There's some interesting stuff there, but in any case, like it's on that order. It's not that deadly as far as it's not like super deadly the way it is for older people. I mean, for young people, it's you know, and so that age stratification matters for policy also. Right. So, because now we know who we have to protect, who we have to work really hard to protect, and who it's sort of, you know, it changes the balance of costs and benefits, right? When you think about thinking about that age stratification. That's where I thought.
In your LA or the Santa Clara study, you probably didn't have enough power to get a good read on the IFR per different groups, right? You didn't, for example, sample enough children to get a sense of.
So LA, we didn't do children. In LA, in Santa Clara, we did do children. So the prevalence looked pretty close. We didn't end up reporting it in the main paper, but we've now done that calculation. I don't know if you can tell. I mean, statistically, there are statistical difference between old and young. You know, even in the Santa Clara sample, because the actual point estimates are so large. The difference is so large. Actually, at that time, not a single child had died in Santa Clara from it. In fact, I think that's still true.
It's still probably true, right? Yeah. Yeah, the numbers are so low. I mean, it's almost like it's hard for us to even pinpoint that to COVID. If you look at the numbers being so low across the world on
in children. I mean, and that's, you know,
like
that's
this might be a you know, unhealthy children dying for various reasons. And
I have to say, like, when the thing first hit, like, I worried, what do I, you know, will I bring the COVID home, because I had to go out and interact with some people occasionally. I'll bring it home, and after I saw the study results, I thought, okay, that's a huge blessing that we don't have to worry about that for our kids. But right. Just imagine if it were the opposite. You know, you have the 1918 flu, which which killed young people. That's a hugely different optimal response there, I would think.
So let's fast forward a little bit and then think about all the other IFR studies that are now available.
50, and they find the same. Okay, I'll be a little careful because I'm talking to someone who knows statistics really well. So our number is in the median of where these IFRs, of these studies, these seroprevalence studies. Now there are 50 plus of them done in places all around the world. Right. In places like Japan, it looks like the IFR is lower. In places like Spain, it was higher. And we're the median. We're pretty close to the median, 0.26. So somewhere between 2 in 1,000 and 3 in 1,000 is the IFR, I think. And so, you know, just to nail that home, that means that if you get infected, that somewhere between 997 times out of 1,000 to 998 times out of 1,000, you will survive the disease. Okay, that's
With
what
of
the
course the caveat being the big stratification per age, right? So we know now.
and also there are other things I didn't mention but are really important as well. So they're like, if you have some comorbid conditions, it seems like you're in it. It makes you put you at higher risk, things like that. Which, I mean, we'll learn more as time goes on, but I think we already know quite a bit about that.
Right, right. Actually, yeah. So my brother in Brazil got diagnosed with COVID, and he has two of the comorbidities. He's a little older than me, and high blood pressure, pre-diabetes, and we're like, oh wow. But then so he actually got hospitalized for a couple of days for no reason, just for observations. And I remember talking to my mom. I was like, listen, look at the numbers. Even in his condition, we're talking here at maybe 1 in 1,000.
Yeah.
Maybe no, a little bit more.
Oh, yeah, a little more, but on that
yeah,
order.
A little more. Maybe, yeah.
But it's look,
It's
I
still
think
less than 1%, probably.
yeah, I mean, certainly less than 1%.
Right,
I mean, that's what the Imperial College model said. I mean, and look, I think 50 studies that find roughly what we found. I think we got the science right. I think Twitter got it wrong. But which is, I mean, not to say Twitter was bad. I mean, it was actually, like I said, productive to have that scientific discussion, so we can know if it was we were finding something robust or not. But the real test is replication, and we now have replication studies from around the world that found the same thing.
Right. And in addition, right, I think we have the sort of like the assumptions about number of deaths associated with an IFR 1%. We're maybe 2.2 million deaths, and we're like order of magnitude away from that, right?
Yeah, it's 200,000.
Of course, there's two things going on, which is the infectiveness of it, and all the measures that we put in place, and all the things that we're still doing that clearly slow down the progression of the virus. But still, I mean, I think the best case scenario with all the mitigation measures of those models, we're still talking about an order of 1 million people dying.
Yeah, I think those models were grossly mistaken. And there were people like John Eades saying that at the time, right? That we don't have enough data, and that was my instinct as well. That we didn't have enough data to make the call. Now, why does it matter? So I think if we're talking about policy, we have to account for the uncertainty in this decision making. We can't make the decisions as if there's only one side to it, which is what I think we did. We saw the models. We said, okay, this is saying millions of deaths. Well, what's the harm in shutting down for a little while?
Yeah.
What's the harm, right? As if there were no costs to that whatsoever. And I think this is where economists failed. At that point, I think economists as a whole should have risen up and said, no, you need to think about the costs and the benefits. And I think there was a very easy rejoinder that drove many people away from that argument, which is that the costs as they were argued and specified in Twitter and other places was on economic costs. Oh yeah, your GDP will get hit for a little while. Who cares? Lives are more valuable than GDP, which is true. I think lives are more valuable than GDP. But the point is that it wasn't just GDP on the other side. It's lives on the other side of that as well. And we've seen that, and we're going to continue to see that, I think, for a very long time, actually. So I think at that point, we should have been saying things like, look, if you shut down the economies of the whole world, which is essentially what we did, the number of people who depend on those economies functioning well is absolutely enormous. I think I saw some numbers. We've raised 1 billion people out of poverty in the last 20 years with GDP growth in developing countries worldwide. Right. So I grew up in the United States, but I was born in India. When I was born in 1968, I looked this up at one time. My life expectancy at birth was 48.
Oh wow.
48. I'm 52. A kid born in India, a male born in India today is like 60 something. I mean, enormous progress. That progress is not magical. It comes because of economic growth. Reversing that economic growth has consequences. So like the UN, for instance, are saying that 100 million people worldwide will starve as a consequence of the lockdowns and the economic shutdown. Gavi, which is this program that does immunizations worldwide, shut down its operations. We will see a resurgence of polio and measles worldwide as a consequence of this. Deadly diseases. Tuberculosis is going to have a comeback. Already has come back. 1 million extra deaths of tuberculosis potentially because in order to treat tuberculosis, it's not just a one time you get an antibiotic. You have to keep coming back, time out, like week after week or whatever, to get the new dose. You stop that program, and those people will die from tuberculosis, and they'll spread it.
Cancer diagnostics, probably, right?
Cancer. So cancer. We have actually had success story in the last few years where cancer mortality in the United States fell for the first time in living memory. That is going to be reversed almost certainly, because not only did you get people not coming in for their cancer screening, so we're going to see later stage breast cancers, we're going to see later stage prostate cancers, colon cancers than we otherwise would have seen. But we also saw people who were more afraid of COVID than of cancer. They had cancer. I mean, it's sad to think about, but it's exactly what happened. There was a little bit of a mystery for a while. Why weren't people coming in for heart attacks? Looks like COVID cured heart attacks or something, right?
And strokes as well, right? Strokes. That's how there was like the number of stroke patients, they disappeared.
Yeah, and so what was happening? People were dying of strokes and heart attacks at home rather than going to the hospital to get treated. Where we have excellent treatments for heart attacks now. And, it's just much safer. I mean, if I had a heart attack, I would go to the hospital. I mean, you have to.
Right.
So those are costs. Those are lives. There is no riskless option, which is what economists should have been saying at the time. But instead, what I heard economists saying was, "Oh no, we have to. It's okay to stop. There's this worst precautionary principle. There's this worst case. Let's focus on that." That is no guide for action, because especially in a situation where there's massive uncertainty and you don't know, and there's risks on both sides.
Yeah, and if you take the precautionary principle, you don't go out and drive, ever.
Yeah, well, I mean, but it's even worse than that. Like, that's true. I mean, there's this reductio absurdum kind of thing. But there's also, when you have a situation where there really are risks on both sides, which risk do you mitigate? Precautionary principle doesn't tell you anything about that. You have to use a good old-fashioned economic analysis, like think about the cost and the benefits carefully, assess the risk. I mean, it's hard, but you have to do it. And you can't let people that are pushing a particular policy because of fear basically intimidate you into doing those careful calculations on both sides.
Yeah, and the sort of like fighting words of like, no, you need to trust the science, as if the science is a settled thing. And as you pointed out, right, there's no settled thing at all in the science. Here's how the science was not settled. It's a bit of a joke I made with my students today. If I was a flat earther, and I predicted in March 0 deaths and 0 hospitalizations by COVID, I will be closer to right than epidemiologists in Texas.
That's true, actually.
I mean, my mean square error will be smaller than the predictions made by the experts. I mean, that's atrocious.
Right. I mean, and it's as if there was this like sense of like any mistake on the upside is harmless, and any mistake on the downside is going to kill people. That is just a mistake, like an enormous mistake. And it's an enormous mistake that economists should have known better, should have been crying foul on from the beginning.
And you point to economists. I've been very critical to them as well, in the sense of like, where are they when we needed the sort of adults in the room making these cases very strongly? They disappeared. Statisticians also disappeared. I think John, I think John is somebody that in the statistics field is incredibly respected, and my profession somewhat was very quiet throughout this whole thing. We know the badness associated with the epidemiological models. We look at them in 5 minutes, like, whoa, hold on. And we didn't say anything. We did not go.
No, but they were too busy attacking the standard errors in the Santa Clara study. So you got to.
That's right. All right, so let's go to a next topic that I think it's also incredibly important to what we're living right now. To some extent, I think the preference of people won over the politicians, at least in the U.S. But like, even though in California you're still more in a lockdown setup than I am here in Texas. For the most part, I think people said like, no, we're seeing the risk out there and we're living our lives, adjusting to our best to do that, even though they're being bombarded constantly that, oh no, we haven't done enough. Like, well, I don't know what enough would have been. I don't know what the options were and so on. But here we are at a point where lots of things are open, lots of things I can do, but lots of kids in the state of Texas and most states in the country cannot go to school still. And so what do we know about the evidence associated with kids? Not only, we talked about the IFR only as being much lower, like perhaps close to zero for kids. But what do we know about their sort of contribution to the spread of the disease?
Yeah, so I mean, I think that what you started with is the most important point, which is that it's safe in as far as COVID is concerned to send kids to school. The risk they face from COVID is vanishingly small. And in fact, to kids themselves, the risk of not going to school are higher than going to school by an order of magnitude. Kids are where.
What are those?
So for instance, like kids, school, so I study school nutrition. So like like a very large fraction of kids, a third or higher, get their meals, subsidized meals or free meals through school. A lot of their nutrition happens in schools. If you have special needs, that's where you get your help. If you have, like socialization takes place in schools. It's where like people get psychological help when kids are going through tough times. It's not just the education, but as well we know that even short duration stoppage in educational activity can have very long-run health consequences. There's an enormous econometric literature that establishes this. So it's not just that you're reducing, job prospects in the long run or education.
Right.
It's not, you can't make it up. Like how do you teach a first grader to read on Zoom? It doesn't. I mean, just think about it. It just doesn't make any sense, right? So I think schools are enormously important for children, developmentally, psychologically, nutritionally, in so many ways. Whereas like having them stay at home is no substitute for that. Even learning from home is not developmentally appropriate way to teach. And okay, so that's first thing. So it's safer for the kids to be in school than not. Then the question is, how about the staff? There you have to look at these studies of spread of the disease. So let me just tell you about one study, which I think is my very favorite study in the whole epidemic I've seen. It's a study published in New England Journal of Medicine, done by this group in Iceland. And what they did there is they got a sample of 12% of the Icelandic population, like representative sample of 12%. It was a very large scale study. They tested every single one of them, and they identified the virus from all of the positives in that 12%, not actually all of them, but some subset of them were positive. And then they sequenced the genome of every single virus. So the virus itself mutates all the time. The mutations mostly don't change the function of the virus, but they serve as a sort of a fingerprint of, so what virus you got. And so, for instance, from that you can tell, like I have mutation A in my virus, you have mutation A and B in your virus. I could have passed the virus to you. That's possible because we share A, but it's unlikely that you passed it to me. Right. And if you have A, if I have A and you have B, and I don't have B and you have A, then I couldn't have passed it to you. Right. Right. So based on a careful contact tracing study with this representative population and this mutational analysis, they determined exactly who passed the virus to whom for every single person in Iceland, for this 12% in Iceland. Yeah. So, and it turns out that, and this is the absolutely shocking result, there wasn't one single instance of a child passing it to an adult. Not one. A lot of instances of adults passing it to children, not one single instance of a child passing it to an adult. Children do pass the disease on, like other children can get it from them, but they seem like much less likely to spread the disease than adults. And part of it is that for the most part, when children are infected, they get a mild form of this. Many of them are not symptomatic at all. If you're asymptomatic, you can spread the disease, but much less efficiently. Right. The disease is spread by droplets. And if you're sneezing and coughing on somebody, you're more likely to spread it to them than if you're
But the amount of virus you have inside of you also, if you're not having any symptoms,
well, so
small, right?
I mean, so it does turn out there are studies that say that the kids have the virus there, but it's not causing the symptoms that allow them to spread it.
Huh. So it's not that they have some sort of degree of immunity, they're able to fight it off earlier. It's just that they don't develop the symptoms.
Yeah, but I mean, partly that's because of their immunity, right? That's one theory, is that there's like this cross-reactive T cell immunity that they have it preferentially over adults, that protects them from getting severe symptoms. I mean, they still can get sick, but not really sick.
Right.
And so I think that's one of the theories. In any case, the empirical fact is they don't spread it.
Right.
And now at this point, now no one's done as careful a study as that Iceland study. But now there have been contact tracing studies around the world around kids, and they find monotonously the same result over and over. In the UK, that was the single largest study, found the same result. Ireland, Greece, South Korea, which actually there was a New York Times report reporting the opposite. But when there was a second revision of that study that found that in South Korea the kids don't pass the virus. There are studies of school openings and closings which seem to have almost no effect whatsoever on disease spread. Schools are not the nidus of the spread of infection. So what do we learn from this? The teachers are at more risk from other staff and other teachers than they are from kids. And there's a study comparing Sweden and Finland. Sweden, they left the schools open all the way through the epidemic, up to age 15. No masks, no restrictions, no nothing. And what they found, there was no kids, by the way, 0 kids dead from the epidemic.
I'm going to quote here from because I have the number, is 0 kids death out of 1.8 million kids going to school through the whole pandemic.
Correct.
Right.
I mean, that is stunning, right? So it is not now I don't want to say that there's no risk to teachers, because there are risks. I mean, like I said, from other, and I think but we kind of know who's at risk. If you are an older teacher, there ought to be some accommodation for people who have high risk. Absolutely. So maybe the older teachers can teach via Zoom, or they can help the younger teachers who can be in the classroom together. They can get reassigned to places where there's, things like that, I think are reasonable accommodations to account for the fact of risk. We should take the data and act on it in that way. But to decide to not have in-person school at all, I think is immoral.
Yeah, no, it's hard not to think in those terms, and because you mentioned something about the sort of short-term interruption to school being problematic and causing health problems to children, right? We have a large body in literature, also in economics, about the long-run impact of the summer on poor kids in particular. So
Yes.
Our kids in the summer, they get a bunch of enriching activities. They don't lose any reading time, any math time, and so on, right? Any math ability. But lower income kids suffer a lot from the summer. So now we just had 3 summers in a row for some people.
I mean, I used to love summers, but that's this summer was harder than the typical one, I think. But the inequality effects, Carlos, you're absolutely right. I mean, it is mind-boggling.
Right.
Whatever progress we've made in closing those gaps in inequality are gone overnight. I saw this picture in the San Jose Mercury News, which just is so it's of 2 Hispanic children. It couldn't be more than 7. Sitting outside on a curb outside of a 7-Eleven with their little Google Chromebooks that their school had given them because they didn't have Wi-Fi at home. They're sort of leeching off the Wi-Fi of the 7-Eleven or whatever Taco Bell. I mean, it's just how do you square that with our commitment to reducing educational inequality? I mean, you just can't, right? You have to say, okay, I care way more about the kids' well-being? No, you don't care about the kids' well-being. You care about something else if you're going to allow that to happen.
Yeah, and you should, in the transfer, it's a transfer of a cost, right? To people that are benefiting. I say that perhaps the very old and vulnerable are benefiting from this at a cost that we typically don't think about that transfer going that way so clearly, right?
And Carlos, we did the exact inverse of the right policy implied by the evidence. We quarantined the healthy and the young, and we've exposed the old and vulnerable to the disease. I think 40% of deaths, 45%, a very, very large fraction of deaths are in nursing homes.
At first, you might say that it was just like, we didn't know enough. Perhaps by the time we realized what was going on, nursing homes were infected already in a lot of places.
I mean, to be fair to the United States, I mean, that's the same thing actually happened in Sweden. Like there was exposure in Sweden of nursing homes. It happened in many, many places around the world where it was in early days difficult to pretend, but I think now we know a fair bit about how to isolate. And we should be using our testing resources there,
Right.
where it would actually make a difference. Like if you want to enter a nursing home, you should have a rapid test done on you. And if it's positive, even if it's a false positive, I don't want you in there. Like I can't tell.
That's right. That's right. So let me go to then the confirmation testing, because then you wrote recently an op-ed in Wall Street Journal where you basically advocate for us stopping testing healthy and young folks, and that goes against a lot of I think what's been conventional wisdom, even in the sense, well, if we test them more, things are gonna not be a problem. In some ways, if you think about, testing could be akin to a vaccine. If everybody was testing themselves every day at home before leaving the house, that could essentially work as a vaccine, right? But so why go through your argument, because I think that's important to make the distinction.
Okay, so I think that, like, first we should actually take on that alternative, because I think that has driven a lot of the discussions. It's incredibly misleading. That testing regime where we test everybody every day is not possible. It's not in the feasible space. Not just for technical reasons, like just getting the capacity to run that many tests is not technically feasible, but also just behaviorally, right? So if I really have to go outside to feed my kids, am I going to take that test? Is someone going to monitor me to make sure I take that test? It's not behaviorally consistent. Like you're going to voluntarily ask people to pay a cost where, especially where like they don't feel sick, they just feel, right, and they get a test. Now, if you did do these kind of things, you would have to have like once these rapid tests that actually have a fairly high error rate, both of false positive and false negatives. I feel fine. The test says it's positive. If I miss work today, I don't get a paycheck. Am I really going to say, okay, I'm going to stay at home voluntarily? You're asking people to pay costs for an external benefit that is uncertain.
Right.
It just doesn't, from a policy point of view, be very difficult to put a regimen like that in. And I think we've focused on that because we think about test as this perfect thing that's cheap and easy to do. And my God, how come we the richest country on earth, can't get 100% of the population tested every day into eternity? That has never been reasonable. And that alternative has driven a lot of policy. So like this dogma of test, contact trace, and quarantine has driven policy. Now that dogma works in very limited settings. Right? So it works in very limited settings. It works when there's very few people with the disease. The disease, in venereal diseases, it works great because the disease lasts pretty long. You don't get cured of it by yourself. You can test and trace. You can figure out who the full network of people that's exposed you to the disease, and then isolate and treat those. Right. So that works great in that setting. When you have a disease that's, in the early days, 40 times more common than you're seeing in cases, and now probably 10 times more common than you're seeing in cases, how does that work? Especially when a lot of it's asymptomatic, it makes absolutely no sense in that setting.
There's a whole idea, even the premise of contact tracing, by the time we realized what was going on, that was completely out of the bag, right?
Yeah, I think it's useful for studies like the Iceland study and other settings in order to understand epidemiologically the nature of how the disease spreads. But there's a very different thing than using it to control the disease, to control the spread of the disease. I think even by March, it was too late for that. The countries that were successful in controlling that had done it very, very early on, where there were still very few cases. So most famously is South Korea. They found a super spreader event, they identified everybody, they controlled this contact tracing thing, they controlled the spread with this app. But you know what? The cases just come back there. New Zealand famously identified every case, shut down the borders altogether of this island nation, and there were no cases for 120 days, and yet all of a sudden it pops up and now they've shut down again. This disease is very infectious. It's very unlikely you're going to be able to stop it from spreading. The question is, who's getting it, what risk is posed to them, and what are the costs of shutting them down? We can also talk about false positives with the PCR test, because that I think is an important thing, but even I don't need that argument for this. If you test in college campus settings, You will find cases, guaranteed. We found them.
Right.
But what you won't find is very many cases that result in hospitalizations and deaths. Kids are going to be kids. I mean, I teach college kids, and I was once a college kid, and
I know.
you know, I mean, like it's just normal developmentally for kids to interact with one another. You can't ask them to isolate themselves forever.
And behaviorally also, if they understand that the risk to them is incredibly low,
yeah,
they're not going to act in that, right? So
yeah,
they have more risk taking anyway. And if the risk is told to them to be very low, then well, it's going to be hard.
And we can't lie to them.
Right.
Just we just have an obligation to tell the truth, right? We're basically saying, let's test, and then what? We have 10,000 cases on your college campus. What am I supposed to do with that?
Well, the political pressure and the media pressure is going to be to shut it down, right?
Yeah, I mean, that's exactly what we'll do with that. But the harm from shutting it down is certainly more than the harm from keeping it on going. Now it might be important information. I think, for instance, for college professors, we should take. I mean, I personally would be perfectly fine teaching, in person. I'm actually okay with that. But I can understand professors who don't want to take that risk. We should make accommodations, just like we do with for high school or sort of elementary schools. We should have accommodations for people who for that fact. So, teach outside if it's feasible. If you're not comfortable, then fine, do Zoom classes for especially if cases are spreading. I mean, you can do this without denying the kids who go to college an actual college, an opportunity for actual in-person dorm education.
Right. And then that's so far at UT at least, I think we're looking at a prevalence about 10% of the students. I think with the tests that they're being conducted, and so far, our administrators have been pretty steady on like, well, we'll manage this. This is fine. This is not a problem. And meanwhile, the public health officials in Austin, which don't have control of our decisions, it's kind of an interesting governmental, like we live under the governor inside of the UT campus. They've been, yelling bloody murder for months on, like, no, you can't open, you have to shut it down. We had a football game this week here with 15,000 people in the stadium, and they're like screaming at the top of their lungs. Perhaps that's not a great idea.
Yeah, I'm not sure
I'm not sure it's a great idea.
Yeah.
But the campus being open, like, unless there's something, as you pointed out, unless there's like a huge impact on the progression of the disease elsewhere, and there's no evidence of that, right? And
I mean, I think, as I said, it's not that there isn't asymptomatic spread. There is, but it's much less efficient than symptomatic spread. So, you tell kids who are symptomatic, stay in your dorm, self-quarantine. They'll do it because they're symptomatic. If you tell an asymptomatic kid, oh yeah, you got this positive, I'm feeling, I had no symptoms at all, stay for 14 days and isolate yourself. I mean, it's harder. It's much harder. And I think, I think that like taking human nature into account when we're doing these kind of policies is really important. And I think a lot of the policies are just, it's as if we're going to automatically obey when people just don't. Like, they're going to consider the costs and benefits to themselves very carefully when they're deciding whether to obey.
Right. So go ahead. I was going to close it up, just, so don't take more.
Yeah, well, let me just close the loop on the college and on asymptomatic testing. I think the balance. I wanted to return to the false positives, because there actually now is some evidence the PCR tests themselves have a false positive rate. So the PCR, the way that the test works is it amplifies the genetic material by doubling. Mm-hmm. Right, so you put a little bit of like you run one cycle and it doubles the genetic material. Each time you run the cycle, if the virus is present, or the part of the virus you're looking for is present, it'll double 2, 4, 8, 16, 32, right? Normally, like you would run it until the virus comes up to a detectable level. Now, if the virus isn't present, you do the doubling. 0 times 2 is 0. 0 times 2 is 0, so you get nothing, right? It turns out there's emerging literature that the number, if you double enough times, you will amplify non-infectious viral particles. That you will get, essentially, even though it's not a false positive, you get a functional false positive, a positive that's not actually likely to be infectious. So this functional false positive is really important because it depends on the number of cycles that you do this. So if you go 32 to the 30th, that seems like actually turns out to be pretty good balance. You've amplified things that are, you're still going to pick up some functional positives, but false positives, but you're not that many. But after you do about 35, 37, 30, that many cycles, it turns out almost all, if you're negative up to 34 and then the 35th picks up a positive, that 2 to the 34th picks up nothing, and the 2 to the 35th picks up something, you actually have almost 100%, very, very high rates of functional false positives. Maybe 40 cycles. I mean, there's the literature still is, at least to me, unclear on exactly where that threshold is. A lot of the cycle times for the PCR tests are higher than 30 in labs throughout the United States. I think it's Paraguay that seems to have done well with the epidemic. Their cycle times are 30 in their labs, or lower. And so it looks like they don't have any cases because they're not picking up cases where it only shows up positive after 35 cycles, after 35 doublings. So I think there is some increasing evidence that there's false positives from these PCRs. And if that's true, it makes the argument against testing asymptomatics even stronger, I think.
Stronger, right? Because the probability, if you're looking at somebody, there's a probability that's low enough to begin with, right? You just like the probability of the posterior probability is going to be even lower, right? Than you think, right? Which again, if the decision making associated with that, right, impose a huge cost without much of a benefit, that's exactly what's missing from the calculation.
Yeah, right. So it sounds like a counterintuitive argument. The question is like, what do you do with the information? Use the test to save lives. Use the test to make sure that no one enters a nursing home that's positive. And fine, if you have a false positive and you leave someone outside the nursing home, that's better than exposing somebody. To balance the costs and benefits there point toward excluding people who have any chance of being positive, right. Or indication of being positive. Colleges, can kids go, 18 to 20-year-olds hang out with one another that are asymptomatic? Even if I get some positives, I mean, I'm just not going to, it's hard for me to get excited when it doesn't result in people ending up in the hospital and dying.
All right, so where we go from here? What do you think? What's your sort of general prognostics? Where I know that's a difficult question, but like,
okay, let me start with my.
I used the word wrong. I think that just with your forecast, I think, what do you think? In terms of the disease progression or types of things from a.
Yes, so there's two schools of thought on disease progression. So one school of thought is that we're not going to see a second wave. We haven't seen a second wave anywhere yet, really. What we've seen is regional epidemics with a big burst, essentially a harvesting of lives, unfortunately, and then a decline. Right? We saw that in New York, and the question is like, how high does the peak reach? Will that? And there's one school of thought that says, look at Sweden. They have had no second wave. Their deaths are down to zero. They've not locked anything down. If it's going to run through the population, it's kind of run through the population.
Right, they're done. Right.
They're done. That's one school of thought. Another school of thought is that, look, it's seasonal. There might be a second wave. I don't know enough to tell the difference yet between those two views. If you pin me down, I'd say that the first school is more likely true, but I have a lot of uncertainty around that, I should say. I think what we've learned about the lockdowns, even if there's a second wave, I do not think there should be a lockdown. Not a general lockdown. We should use what we've learned, which is we know who's vulnerable, and focus the lockdowns on those populations and let everyone else live their life. Controlling community spread as a way to protect the vulnerable is too costly.
And I think we've seen that even in the very hard hit areas, we never overwhelmed the hospital capacity, which was one of the arguments in the beginning that, well, we're not going to be able to manage the onslaught of cases. And I
think like Italy did. You might make some argument about
that. There was like a few days are real bad, and then it went away, right? So yeah, it was not great. I'm not going to suggest that was not dramatic what happened in Italy or even in New York City for a week or so there, but again, balancing through the cost. We just saw in Texas for the last, since May, as we reopened here, that yes, the wave came because we didn't have it. We locked down before anything. The wave came and in fact peaked much earlier than I think what some, well, much earlier than any epidemiological studies would expect. And it's hard to explain why would it gone away, given that the behavior changes are not in place. So,
yeah, I mean, like, so like,
the way they did in May.
I mean, herd immunity is a dirty word, but what is it actually? So herd immunity just means that on the margin, an additional case results in one or fewer additional cases, so that the total case numbers daily are coming down rather than up. Okay, there's not a single herd immunity number in that sense, because that has to do with the structure of the social network in which the disease passes to one another. So if you see cases declining, people start interacting a lot, you may see cases go back up, and then then they'll take more precautions, it goes back down again. I mean, if that kind of idea about not one herd immunity number, but sort of a dynamic response to the risk privately, I think that's likely to happen, continue to happen in this. So I think that in that sense, Sweden's not in herd immunity.
Right.
It's given the set of social circumstances, social interactions they currently have, they have very little spread. Texas is on its way down. It looks like it's, but if cases go up, maybe people will change their social interactions again.
And in Sweden, you can say that, well, once winter comes in, people start being inside more, people start being close proximity to each other more, and therefore the social interactions change, and then the thing can creep up again, right?
Yeah. So I don't think we're done with this in that sense. I do think we have to learn to live with it, right? So we have to learn to live with it, actually live, not just hide, which is what we've been doing. I think that we have to understand that there is no safe alternative here, and that's going to continue to be true. Now, there's going to be a vaccine. Well, I should be careful. It's likely that there's going to be a vaccine. It will be statistically difficult to prove that the vaccine works for deaths, because the setting is the vaccine is tested in a setting of declining cases and deaths. So if we run the vaccine trial in a setting where there's no cases at all, you're not going to find a statistically significant difference, right? It's going to be harder to find. You need much larger samples to find a statistically significant difference. So there'll most likely be an intermediate endpoint, rather than deaths, maybe cases, or rather than cases, maybe protective immunity, T-cell immunity, or some sort of measure of immunity. I don't know. The key question for the vaccines is how safe are they going to be, and I think that there's going to be, and I just know from personal involvement that there will be a very rigorous process to see if the vaccine is safe. In fact, I think that AstraZeneca's trial just got stopped because they found one case of transverse myelitis in this adenovirus vaccine platform. So I think I'm hopeful. Actually, if you'd asked me 6 months ago, would it be possible to get to this stage where we have all these vaccine candidates in September, I would have said there's no way. So in that sense, like, we've done, well, yeoman's work to like get to this point. I'm hopeful, but we'll see. The vaccine could change things, right? Especially if there's a safe and effective, somewhat effective vaccine. I don't think it'll solve the epidemic, but it'll make a lot life. It'll be like more like that H1n1 like we started the conversation with.
Anyway, Jay, thank you so much for joining us. This was wonderful.
Yeah, thank you, Carlos. Pleasure. Take care.